Good evening, everyone. I hope you can all hear me loud and clear. Can you hear me?
Yes, we can.
Oh, good. Thank you. So I welcome everyone. Let me say, Nigerian Health Historians Network welcome everyone to this seminar. And as you all know, the seminar today is on humanitarian medicine and public health emergency response in Africa. Just say this, it is essential to acknowledge that Africa has a long history of traditional healing practices, and these practices often passed down through generations, then reflect profound connections between health, spirituality, and community. And Afrocentric humanitarian medicine recognizes the importance the importance of respecting and integrating these traditional healing methods into modern medical interventions. So this not only ensures cultural sensitivity, but also enhances the effectiveness of healthcare delivery. So today we have some professors, some reputable personalities that will unveiling humanitarian responses to us. And we have a Bertrand Taithe, who is going to be the first speaker today. And also we have Adebola Olayinka. And also we have Bello George. And the last person, the last speaker today will be Olusoji Adeniyi. And without wasting our time, I would like to introduce the first speaker, who is Bertrand Taithe. I will read his bio, and after that, we have to bring him into the platform for his presentation. Bertrand Taithe is the founding director of Humanitarian Conflict Response Institute at the University of Manchester from 2009 to 2022. He is a professor of cultural history, and since 1999, his research interests are primarily on humanitarianism and humanitarian AIDS practices. He has published on the history of humanitarian medicine and history of humanitarian and missionary aid, and aid in conflicts, as well as on contemporary humanitarian practices. He has worked with MSF Crash and MSF Switzerland on issues of risk and attacks on healthcare. On this note, I want to invite Bertrand Taithe, if I'm not pronouncing your name very well, I'm very sorry, to the platform for the first talk. Thank you.
Well, thank you very much for this very kind introduction, Bayomi. And I'm very honored to be among you, and I feel like I'm not really, I'm not a specialist of Nigerian history at all. So you will have to forgive me that I will not make many references to Nigeria in today's talk. And I will keep my talk fairly introductory. I thought, since I'm the first speaker, maybe I could open up with some big research questions or issues that interest a wide range of scholars, and which might actually enable us to unpack what we mean or may mean by humanitarian medicine. So what I suggest I do, I'm going to share my screen. Is that okay with everybody?
Yes. Yes.
Okay. I'll do that. I will share my screen so you can see a presentation. The first image that you can see here is actually the only one that refers to Biafra because or to Nigeria. It is a heroic image of the typical humanitarian, self-styled humanitarian Bernard Kouchner, who later founded Médecins Sans Frontières. So I want to keep that image as a kind of mythological representation of what humanitarian medicine is, because my argument is that it is precisely not embodied by this image at all. So if we think about humanitarian medicine, the fundamental question is who defines humanitarian medicine? There is a problem of nominalism in the sense that people who actually argued that humanitarian medicine is the medicine conducted by humanitarians in humanitarian situations fail to define what makes a situation a humanitarian situation, or indeed define who is a legitimate humanitarian. Nevertheless, if we think about humanitarianism as being linked to perhaps the development of internationalism of a medical nature, perhaps, and most clearly embodied by the Red Cross and Red Crescent movement, then you have to go back to the 1860s to find its origins. And arguably in the United States, arguably in Europe, there is a debate of no relevance here. But very interestingly, globalizing very early on, since the Ottoman Empire joined the Red Crescent movement in 1867, and the Ottoman Empire had indeed presence in Africa at that stage. One of the earliest form of Red Crescents is going to be the Egyptian Red Crescent, and there will be a lot of international humanitarian aid, south-south or east-south, as early as the 1870s. So, in other words, not a European phenomenon per se, but one that globalizes fairly early on. Originally, war medicine, but very quickly. And this is where the American story is different from the Western story, disaster relief medicine, colonial medicine, I'll come to that in a second, and defined by the notion of emergencies. The problem, of course, is who defines an emergency and for whom is it an emergency? The question that arises, of course, today is how much humanitarian medicine is heir to a colonial past or inheriting from a colonial past. So the main domains of humanitarian medicine are quite varied, and I want to stress that they've been varied for a very long time, in the sense that war surgery enters in the 1860s, prophylaxis of prevention of diseases as early as 1900, the fact that refugee prisoner camps have been a subject of humanitarian activity since 1877, nutrition and famine relief, first of all in Russia in 1919, that there has been major campaigns since the 1920s for medical campaigns of various kinds. And of course that it has defined international standards of care, at least since the 1970s, and has been involved in many pandemics, cholera, HIV, Ebola, COVID, for example. Interestingly, and this is the more important point, of course, is where are the boundaries of humanitarian medicine? It is not at all confined to emergencies. And this is one of the major points, is that humanitarians have been active in health responses, in hospitals, in health systems, and that this intervention has increasingly taken the shape of tackling non-communicable diseases. I was recently in Malawi looking at an oncology program run by humanitarians. So the concept of emergency here has obviously been redefined quite dramatically. So if we go back to the structure of this talk very quickly, is that I want to go very swiftly about the first phase in order to introduce the bigger questions that I think have been arising since. So one point to make about colonialism and humanitarianism is, of course, the fundamental ambiguity of humanitarians in relation to colonialism. Yeah, colonialism was largely justified by humanitarian ideals in a sense that somebody like Leopold of Belgium called himself a humanitarian and appealed to humanitarian fundraisers, in a sense that humanitarians even then started to take a counter narrative to the arch-imperialistic narrative, not necessarily challenging colonialism itself, but rather the methods and means. The classic example of this is, of course, Sir Roger Casement, who is one of the first humanitarians who get a knighthood in the UK for his work as a humanitarian, denouncing atrocities in Congo. But interestingly, what matters here is that humanitarian medicine, when it appears in earnest in the 1920s, will always remain a critique, an implicit critique of modes of government. And that critique of governmentality or governments you find, for example, very explicitly in the campaign against sleeping sickness, for example, by Eugène Jameau, whose career was broken by his political enemies. Humanitarians defined their emergencies in the sense that they actually shaped a narrative around their activities, not unlike that of the missionaries with whom they partnered, and the boundaries between missionaries and humanitarians is often impossible to distinguish in that particular period. But welfare provisions, issues of motherhood, issues of childcare become central to humanitarian discourses. And I'd like to point out the 1930 Save the Children conference in Geneva on African childhood as an example of how issues of health were mobilized by organizations after a major inquiry about labor and childhood and health in that particular period. Of course, one of the great focus, as you all know, was the great endemic diseases and the fear that Africa was undergoing major demographic downturns. And the great endemic diseases throws us back to another range of humanitarians, namely the foundations. And this is where we have non-traditional or traditional non-traditional actors, for example, the Rockefeller Foundation, the heir of which is, of course, the Bill and Melinda Gates Foundation today. These are actors that are actually linked to a capitalistic mode of thinking about health and thinking about global health issues. Very importantly, it's only one aspect of what the Rockefeller was doing. The Rockefeller was actually active in a range of domains. Nevertheless, what is striking from this humanitarian medicine of the sort of apex imperial era is its focus on vertical campaigns, that is, campaigns focusing exclusively on one disease and deploying major resources, and in the process actually deploying a lot of skills uptake. So this picture is taken from a nursing school in Ouagadougou, and it is actually taken in 1937, and it is actually quite an up-to-date laboratory setup for the identification of sleeping sickness. Always, humanitarian medicine plays with politics, and this is where I think it's very striking. So if you take two examples of medical missionaries of the 1930s, 1940s, 1950s, Dr. Adrien Atiman, who was active in Tanganyika and was a very significant vaccinator in that particular part of the world, who left an autobiography, who actually was a sunrise slave who had been sold on the market in Timbuktu, and the ransom was paid by missionaries. So it's a very interesting career from West Africa to East Africa via Malta, where he was trained as a medical doctor by the white father missionaries. And the other character here is Dr. Goa Anisson, who was active in what is today Burkina Faso, and was actually elected as a representative of Burkina Faso in the late years of the colonial empires, and actually politically active in the first decades of Burkina Faso. So interestingly, this sort of medical capital is also a political capital. And I've written about this in relation to to Cameroon, of course, because in Cameroon there is a very unusual dynasty of politicians who always arc back to Louis Paul Ojula, who was himself a missionary, medical humanitarian, who actually shaped power networks around medical forces. But what's interesting, of course, is that the end of the colonial era opened up a range of new orders and new systems, and one of which is, of course, the reinvention of the Red Cross movement. And I think that's one area that has been understudied, but the multiplication of Red Cross national societies and the 1965 Red Cross conference completely redefined the definition of what humanitarianism was supposed to be about. And I think we underestimate in the research that has been done so far, in my view, the role of national societies coming from the new states and how they actually contributed significantly in reinventing the so-called principles of humanitarianism, which are listed here. It's very interesting, of course, that when we talk about humanitarianism, you're talking about diplomacy. And through the Red Cross movement, for example, many African independence movements found their first public recognition through the Red Cross networks. And I think that's a very significant part of the national struggles in many anti-colonial settings. Now, since 1978, I would say humanitarian medicine has changed dramatically. And these are the ways I want to highlight. The first one is, of course, that humanitarian medicine has become much more a business of standardization of practice. The notion of pre-deployment standards appears in the late 1970s, early 1980s, simultaneously for the World Health Organization and large medical NGOs like Médecins Sans Frontières, Doctors Without Borders, who are becoming very large in that period. And there is a strong emphasis on taking their model from emergency medical practices from the West. So for the French is the SAMU, but with a strong emphasis also on access to medicine. And this is where HIV is a very significant moment for the reinvention of humanitarian medicine, because the main query arising from HIV is going to be the cost of the drugs. And the campaign for access to medicine really reshapes alliances. And here we find, for example, an organizations like the DNDi. And the NDI is a coalition of mostly large southern state health systems and Western NGOs. And their aim is to develop medical compounds which can be used in humanitarian situations, meaning by that they're looking for cheap drugs that are reliable and can be produced somewhere else than in the big pharma of the United States or the West. What's fascinating about that period of the 1980s, 1990s, and I'm taking here an example from my research in Cambodia, is of course how incredibly diverse the range of humanitarian interventions are and how unrelated to each other they tend to be. The fact that, for example, you have in the 1990s in Cambodia medical interventions for the riverside people, medical intervention for malaria patients, medical intervention for tuberculosis, medical intervention for HIV patients, etc., etc., etc. So disconnected emergencies, vertical programs to a large extent, but also an emphasis on building medical infrastructures and attempting to transfer those medical infrastructures to the states, the state of Cambodia, which sometimes picked them up and sometimes did not. And I think this is a story that we find. So I'm running, I know my time is short, so I'm going to keep my big questions coming up. But the first question to put on the table is, how much of humanitarian medicine is today the reflection of North-South power relations? It is still the case that large northern NGOs are dominant in discursive terms, or at least in the way they communicate. But if you actually look at who's making the drugs, and you look at the pharmaceutical industry in South Africa, the pharmaceutical industry in India, when you look at the pharmaceutical industry in Egypt, you find that a lot of the big drug providers are no longer northern, but southern. And they are not necessarily more benign. They just happen to be located in a different place from the north. The fact that there is a South-South emphasis that, and if you look at Médecins Sans Frontières workforce, for example, the people who work for Médecins Sans Frontières all the way to the top can come from the south, and most of them nowadays are southern, and that means a Kenyan working in Tashkent and somebody from maybe Cambodia or Burma or sorry, Myanmar working in Kenya. I mean, this is that kind of translation, and this is a new form of internationalization that is allowed, that is facilitated by very large NGOs. But some local NGOs like Alima in West Africa can become coalitions of the very local medical practices, the volunteer organization, and internationalization in terms of accessing fund from the north. I'm not saying the money is still not in the north. The money tends to be in the north and trickle down, but as we know, trickle down doesn't mean very much. But there is a very interesting reshaping of the politics at the moment. In the last 10, 15 years, a decentering of decision-making is starting to emerge. More interestingly, perhaps, is the fact that if you look at NGOs, that is non-governmental organizations, medical non-governmental organizations, you miss 90% of what's going on in terms of medical humanitarianism. And I think this is where we need to take into account the big faith-based organizations, formal big faith-based organizations, and informal faith-based organizations. The fact that so much of aid and money travel through religious networks. Christian, Jewish, Muslim religious networks, and very informal networks. And I've looked recently in the last 10 years, I've looked at the history of a small NGO in my neighborhood and discovered that, in fact, it was organized by a Ghanaian who had traveled to the West to gather the money and organize the volunteers in the North in order to support charities in Ghana that he actually had all the links and networks for. So in other words, the power relation was actually interesting. It was a much more balanced in power terms, and he was a very major figure in that domain. I also want to emphasize that, of course, humanitarian medicine is not necessarily about North-South relations. And in fact, if you look at it in terms of volume of aid, in terms of expenditure, in terms of the number of victims that have been looked after, I would argue that most of humanitarian medicine has been deployed in the North. And it's been deployed in the North in the Second World War, in the First World War, the aftermath of the First World War, but also currently is deployed in the North in places like Ukraine. And this is a hospital train run by MSF that is currently traveling in Ukraine. I'll finish with one last thing, which is, of course, the elephant in the room, so to speak, which is, of course, in what sense is humanitarian medicine a violation of sovereignty? And this is something that arises significantly in debates about localization, about decentering power relations, and about who profits from it. And here I think there's something else going on, which is a little bit different and surprising, perhaps. But since 2010, major powers, China, Russia, a lot of India, China, and a range of the BRICS, if you want, have invested in a new concept developed by the World Health Organization, which is the emergency medical teams, EMTs for short. Now, those EMTs can be taking the shape of a field hospital and be the typical state response to a disaster. So let's say an earthquake affected a country today. Well, now you would have pre-deployed teams, emergency medical teams, which would be representing not international humanitarian feeling or organizations, but states. In other words, the Chinese government, especially the Chinese army, or the Israeli army, or the British government would actually send emergency medical teams, which would be in the business of representing bilateral international aid from one state to another. And that is a development that goes against, if you want, the initial free-for-all of humanitarianism. Humanitarianism being, if you want, the internationalism of individuals and by extension of organizations of volunteers. Here you find a kind of humanitarianism contained and redefined by the priorities of the state. The interesting thing, of course, is how does this turn into action when it comes to medicine or medical response? And I think this is where the recent example of Ebola in West Africa is of course very interesting, especially in the way it reinforces some of the post-colonial links that existed between countries. So for the Americans were very interested in bringing aid to Liberia, the British to Sierra Leone, and the French to Guinea, which is a classic sort of colonial domain sort of bilateral relationship. So ironically, and this is my ironic concluding point, I am not entirely sure that the reinforcement of sovereignty is going to get us out of the morass of colonial relations. There you go. That's my ending point. And I've been very, very quick, so I apologize, but I hope it will open up some questions later on. Thank you.
Thank you so much for that wonderful presentation. Indeed, I so much enjoyed the presentation. So rich, you've been able to take us through the both Afrocentric and Eurocentric humanitarian view, and you've actually unveiled the how political agencies are actually involved in the humanitarian actions, and also the aspect of colonialism in colonialism in humanitarian effort, and so on and so forth. And also you said that humanitarian services embedded in colonialism and a lot, the humanitarian medicine in the north, south. So all this information given today has been awesome and wonderful, and I most appreciate you. And in case if you have any question, kindly start dropping your question in the meeting chat column, because I'm very sure that we have so many people with questions today, and then to accommodate many people, really want you to drop your questions in the meeting chat column, so that by the time the session for session for question and answer comes, to be able to be reading them out, and then we'll be able to provide answers to some of these questions. Adebola Olayinka is currently a consultant with the World Health Organization, working with the Emergency Preparedness and Response Cluster. Prior to this, she had been a research officer for high-threat pathogens and coordinated research on Lassa fever for Nigerian Center for Disease Control, NCDC, working through the World Health Organization. She was senior technical advisor to the DG Centers for Disease Control and Prevention, CDC, and had also worked as resident advisor to the Nigerian Field Epidemiology and Laboratory Training Program. Dr. Olayinka was a professor of medical microbiology at Ahmadu Bello University, with a background in medicine from the University of Ilorin, a master's in public health, and a clinical microbiology specialist. She has been principal investigator on several projects. She has provided technical guidance as an expert for epidemic preparedness and response to several countries across the Afro region. So on this note, Professor Adebola Olayinka.
Thank you very much. I'll turn off my video because of the bandwidth, but I believe you can hear me clearly. So we'll be taking a look at the public health response in Nigeria, and we're going to look at the role of history regarding Nigeria. I'm using Nigeria as a case study. Apologies, I'm not sure what happened. I'm going to reshare my slides. Can you see my screen, please?
Yes, we can see. I can see from here.
Okay, so why are we talking about the history of public health response? You are basically historians, so you know that histories help us to learn about how past systems and governments or cultures were built. It tells us how they operated, how they evolved. And as we understand these past events, it tells us how we got to where we are today, and it provides us with lessons from the past. These lessons help us to avoid previous mistakes and to also create better paths. And there are many lessons we can actually learn from the history of public health response. And I hope that these lessons will help us to shape the future. So looking at public health response, why is there so much focus on public health response? We've heard the humanitarian side, and I'll be talking about the public health response side. In recent years, we've had emerging and re-emerging diseases. Emerging diseases can be termed as those diseases that pop out of nowhere, like COVID. And then we also have things that we call re-emerging diseases, something like the monkeypox, or as it's now called, Mpox. And what these do is to tell us about the need, why our public health systems need to be strengthened. The most recent COVID pandemic brought that out very clearly to the whole world, because not only were the developing countries struggle, we also saw the advanced countries, the more advanced countries struggling and trying to respond to this pandemic. So when we talk about public health response, we need to look at what we've done in the past, what we did right, what we could have done better, learn from that and strengthen this going forward. Now, if there's a lesson to learn from COVID, that lesson is that infectious disease outbreaks can have a huge impact on not just the health of the people, but the economy, the social structures, life expectancy, and just name it. So like I mentioned, I'm using Nigeria as a case study. For the benefits of those who might not be very familiar with Nigeria, it's the most populous African country with a population of more than 200 million. It's situated in the western part of Africa, has 36 states with a federal capital territory. And across these 36 states, we have sub-national units, which are called local government areas, and there are 774 of them. Now, I'm giving this background so that you understand the enormity of providing public health, of providing health care and even responding to emergencies in a nation such as this. We actually say that Nigeria is many nations within one. So the provision of healthcare in Nigeria is currently the function of the 3 tiers of government: the federal, the state, and the local government. So with that, we have what is called the primary healthcare system. We have the secondary health and the tertiary. Now, additionally, at the federal and state levels in the ministries of health, we have the public health department, which is really responsible for the detection and response to public health events, and each state coordinates with its local government areas. And this is just the map of Nigeria and its location in Africa. So now coming to the history of public health in Nigeria. Public health is really about promoting and protecting the health of the people. And in promoting and protecting the health of the people, the ability to prevent, detect, and control threats like infectious diseases is very important. And the truth is, the concept of public health has existed even before we coined the name or the term public health. If you have a look at African local communities, there are several indigenous and traditional ways that have been used in responding to disease conditions. There have been preventive and curative practices that have been in place in various Nigerian and African communities before the coming of the colonial masters. And some of them are still in existence today, even though some may have been discarded, some have been redefined, and some have been upgraded. We have systems like the traditional birth attendants, we have herbalists, and so on and so forth. But looking at how the health system developed in the country, in the pre-colonial era, there were these organized medical care that were organized by the colonial masters, and they had this primarily by the missionary agencies. And so they had different rural facilities around, and they had like bigger stations on the offshore islands like Cape Verde, Fernando Po, which is current day Equatorial Guinea. By early 19th century, those missionary agencies had built health facilities and hospitals, which they owned in Nigeria and across other countries in Africa. By 1898, the ruling government then had now established some government facilities, and the military also had its own healthcare facilities, which were in addition to the existing missionary facilities. And these facilities were called the West African Medical Services, or the government or colonial medical services. And they existed like that. In 1920, Dr. Isaac Oluwole, who was the first public health physician that returned from Britain and became the first African medical officer of health in the Lagos colony then, deemed it fit that it was time to train a pool of Nigerians in country. And so he established the Nigerian School of Hygiene in Yaba. And that was where, for the first time, Nigerians were trained and qualified to become sanitary inspectors. Then by 1954, Nigeria was divided into regions. And each region now had its own medical services, which were known as the regional medical services. And these regions remained operational until Nigeria gained its independence in 1960. So before the independence, there was a 10-year development plan that was introduced to enhance healthcare delivery. And with that 10-year development plan, there was the setting up of the Ministry of Health and several other clinics and health centers across the country. And there was also the setup of some schools of health. Following the region-based medical health services, when Nigeria was now divided into states, then we had the state health services, and that led to the development of the ministries of health, which we have till now. But it began to be obvious that the state alone could not cater for the whole country. And so there were subdivisions into the local government areas by the setup of the Basic Health Services Scheme, which later transitioned to the primary healthcare services that we are aware of today. And by the 80s, we had over 10,000 health centers established in the country. And then there were bigger hospitals, which were known as general hospitals, and then university teaching hospitals and tertiary facilities. Now, before I go on, now looking a bit more closely at the public health response, I want us to be aware of the 5 core components that make for an effective public health response. We have emergency coordination, we have surveillance, self and reliable care, community protection, and access to countermeasures. In view of the time, I cannot tell you the whole history, but I'm going to focus on surveillance. Surveillance is the ability to detect a public health threat. And surveillance consists of the surveillance, the health information part, and also the laboratory diagnosis and testing. So looking at public health delivery in the country, in 1937, the Federal Lab Services was established with its headquarters in Lagos. And that Federal Lab Services now had a bacteriology unit, which was located in Yaba in what was known as the medical compound. That medical compound it was a convergence for several public health facilities. So in that compound, there was the vaccine production unit, there was the Central Medical Library, there was the Federal School of Medical Lab Technology, which is now located in Jos, no longer in Lagos. There was the Drug Manufacturing Laboratory, and the Medical Research Council, which is today the present-day Nigerian Institute of Medical Research. You can see that some of those facilities are currently defunct, like the Drug Manufacturing Lab and the Vaccine Production Unit. But in those days, Nigeria was producing vaccines for yellow fever, smallpox, and rabies. And then there have been many pandemics, and I'll give you an example of 2 and use that to link with the history of public health in Nigeria. The very common flu pandemic of the 1918 and 19 started in Europe, and then it spread to the rest of the world, including Africa. The first case in Africa was in August 19, and it was, the first case was from a boat that had departed from Britain and was in and then birthed in Freetown, Sierra Leone. And then there was another American vessel that went from Freetown to Cape Coast and to Accra. And what happened was that because there was a pandemic and there were people who were already infected, who were exposed and infected traveling, the pandemic moved from Europe, from America, came to West Africa. And by September 14 in 1918, the flu had hit Lagos through the seaports. Of course, with that, many people were exposed, people who walked around the boats or on the boats, and they got infected. During that region, travel by train was the major mode of travel in the country. And of course, Lagos was the central point of the country, and it still is. So from Lagos, many people traveled, and before you knew it, there was flu along all the places where the train had stations. Of course, travel continued, and there were other ships which were berthing in other seaports in the country, like Port Harcourt, like Forcados, Calabar, Warri. And so by December 19, the flu pandemic had spread across the whole nation. Now, another example is the Marburg outbreak, which was identified in 1967. This was identified among 31 laboratory workers in Germany and Yugoslavia, with 7 people dying and 31 infected. And it was found out that they had imported this virus from the monkeys which they had transported. The name Marburg is the name of a town in Germany. So in those days, they named viruses based on where they were discovered. Now, another one which is very present in Nigeria is that of Lassa fever. Lassa fever causes yearly epidemics in Nigeria, and it's endemic in many countries across West Africa. So the story is of January 1969, when there was an American nurse who was a missionary nurse in the Lassa village in Borno State. She became ill, very ill. She was transferred to the Bingham Hospital in Jos, but she died 6 days after onset. And then 8 days later, another nurse who attended to her became ill with a similar illness and died. Now, when the two of them died, there was a doctor and a nurse who had attended to them and also performed autopsy. Within a week, both of them fell ill. The doctor died in Jos, but the nurse, Penny, arrangements were made to fly her back to the US, and they also took the samples with them to the US. And in the US in 1970, the virus was identified, a similar virus across the three. Penny survived after 9 weeks of very grave illness, and the virus was named Lassa after the village in which it was found. Now, why am I telling us this history? I'm bringing this history because for decades after the flu pandemic, after the Lassa fever virus was detected, for many decades after that, the identification of these viruses were not being done in Africa. Even though there were many travel-associated cases outside West Africa, for any testing, they were still being done outside the continent. Until around 1993, when there was a hospital laboratory in Sierra Leone. Sierra Leone is also another country that is endemic for Lassa fever, and they made attempts, but they had the civil war, and then they could not come back until 2004. Meanwhile, in Nigeria, people had been dying. Sometimes they were thought to be serious malaria, typhoid, or whatever it was, and healthcare workers were also dying. And then in Edo State, around 2001, from 2001 to around 2004, there were classic cases which resembled what had been described about Lassa fever. And then there was this man, Professor Sunday Omilabu. He's still alive today, and he's still at the Lagos University Teaching Hospital. He now made attempts and decided to ask for retrospective samples from the Edo State lab and to find out if it was really Lassa fever, and then it was Lassa fever. And unfortunately, as I speak today, there are still many facilities in the country and across Africa that do not have a capacity to make a diagnosis of Lassa fever today. So by 1989, and I'm coming back to the history just to make the case on why there is a need to strengthen the public health system and learning from history. So if we go back to that federal lab service that was in Yaba, by 1986, the government decided to build a bigger laboratory. By 1989, it was renamed the Central Public Health Lab. It was given a bigger building, and then the lab was given additional responsibilities that in order to just looking at TB alone, it should support the diagnosis of epidemic-prone diseases. So between 1990 and 2000, the Central Public Health Laboratory increased its scope and services. By 2006, it was designated as National Reference Lab for yellow fever, measles, and rubella by the World Health Organization. And by 2015, by the West African Health Organization, it was designated the Regional Reference Lab for cholera and other enteric pathogens. So in 2011, the country established its National Public Health Institute, which was the Nigeria Center for Disease Control and Prevention. But it took an additional 7 years, 2018, for the bill for the act to establish it to be signed into law by the government. Now, over the century, there were many diseases that had continued to plague the country. Lassa fever, meningitis, measles, cholera, yellow fever, polio, monkeypox, and even within that period, Ebola came. One of the key things that happened with the establishment of the NCDC was that it became an important turning point in Nigeria's fight against infectious diseases. So in 2016, the NCDC had a new DG who understood the importance of having a national reference lab, and the change began. I'm happy to say that I was part of that change because 2017, I became the first consultant to be asked to ensure that we had a national reference lab within the country. But we didn't have a molecular diagnosis in the CPHL until 2018. 2017, 2018, we also had it in the NCDC. But the good thing is that in the last 5 years, there has been an opportunity for transformation of this 86-year-old public health institution within the country. And by the time COVID emerged, the diagnostic system in the country was better prepared. So this is just some pictures showing us the previous Central Public Health Lab and the current one. And then to the left, we have NCDC. To the right, we have the National Reference Lab now in Gadowa. The CPHL serves as a campus to the National Reference Lab. Now, in talking about the development of public health diagnosis in Nigeria, decentralization played a very key part, and we cannot underestimate the role of other laboratories that contributed to this. So in 2001, due to the recognition of Lassa fever, endemicity, and high burden in Edo State, the government set up the IRA Specialist Teaching Hospital as a center of excellence in the management of Lassa fever with 2 other federal tertiary health institutions. By 2008, the ISTH had built a diagnostic and research laboratory which started operation in September 2009 and was able to diagnose Lassa fever. We remember in 2014 when we had the first case of Ebola. To be able to make that diagnosis, the sample was first tested in the same lab that showed the first interest in Lassa fever. And then this was samples, we also shared them with the Redeemers University, and they confirmed the Ebola. We remember also when COVID came, by then, we had quite a number of labs that could test for COVID. So where are we now with regards to public health diagnosis within the country? We have an improved capacity for detection of public health threats. Lassa fever, COVID, monkeypox, diphtheria, these are all being tested within the country. We have an improved surveillance, so it's not just guesswork. We're able to confirm in the country. We have a national reference lab with the biobank, and then this provides coordination with other labs across the country. And then there's a sample transportation mechanism where from every capital in the country, samples can be sent to that lab. And the lab is also working on quality assessments with other labs. With time, we've had many states in the country having state public health laboratories. University research laboratories are there, teaching hospital laboratories are there. There are many research institutions across the country who contribute to this surveillance. And then a lot of these labs have been pulled into different networks for various diseases. So what are the lessons to learn from history? You remember at the beginning I said, we look at history so that we can learn lessons from them. One of the key things that every country, Nigeria and every other developing country, needs to learn from history is that it's important to have a strategic plan for development. What are the goals? What are the objectives? But beyond having the plan, it's important to monitor that plan and evaluate and make sure that it's being implemented. The other lesson is that funding is critical. A lot of development did not happen because there was no attendant funding, even when plans were developed. One thing that has helped the country has been the value with partnerships and strategic collaborations. And then the country needs to invest in capacity building, invest in the people, invest in structures, invest in systems, and invest in materials. One other thing that developing countries will need to really focus on is innovation and adaptability for the things that are prevalent within our countries. And then we need to focus more on research. And we need to go beyond basic research and look at applied and transitional research. And last but not the least, technology development, production and industrialization. A typical case is Lassa fever. 54 years since the discovery, there are still no vaccines for this disease. There are no approved or tested medications. There are no rapid diagnostic tests. And you look at the rapidity with which vaccines were developed for COVID, with which vaccines were developed for Ebola. And sometimes you ask yourself, is it because Lassa is a disease that is limited only to West Africa? Is the world waiting until it becomes a pandemic like Ebola before they respond rapidly? So finally, I want to acknowledge the following people that I know personally who have been very key to some of the recent developments we've had in public health in the country. Dr. Adeniyi, I spoke with him and he's been a part right from the federal laboratory up till the NCDC lab. He was the first director of the lab. He's retired now. And he gave me a lot of this history. Sunday Omilabo, I've mentioned him. The next three are the various leaders of the NCDC, the staff, and then all these other people who have in one way or the other contributed to the public health history of Nigeria. Thank you, and I stop here.
Oh, thank you so much for that wonderful presentation. You've taken us through the history of public health in Nigeria and the need for humanitarian response and services in Nigeria, and also the impact of COVID-19 and Lassa fever in Nigeria that actually calls for the need for humanitarian response in Nigeria. So thank you so much. We are really appreciate you. I think I've learned so many things, from that wonderful presentation. And without wasting time, I would like to invite the next presenter, the next person that is going to give us a talk, and the person is Dele George. Dele George is the founder of the Little Saint Orphanage, an orphanage devoted to the care of abandoned babies, motherless children, orphans, widows, the poor, and unprivileged in the society. She has a background in accounting and a pioneering career in the banking industry. However, she gained she resigned, and since 1990, she has devoted her service to looking after the less privileged in the society. She initiated the foundation of the Association of Orphanages and Homes Operators in Nigeria, ASOHON, in 2009, which is made up of orphanages in the 7 geopolitical zones in Nigeria. From 2009 to July 2020, she was the president of the association She's now the current chairman of the board of trustees of the association. She has received many awards for humanitarian service and motherhood of goodwill. So on this note, I would like to invite Dele George for his own talk for just 10 minutes. And don't forget, you can also view our live streaming online. The channel will be made available to us on the chat page shortly. So if we have people who want to join via YouTube, so they can actually do that. Thank you so much.
Yeah, good evening, everyone. It's such a privilege to be here. I'm grateful for the invitation. The session so far is very educative. Thank you to all the speakers. Like you've heard, my name is Christina Bamidele George in full. I'm a minister of the Gospel of Jesus Christ. So my organization is faith-based. And like one of the speakers said, you know, a lot of solutions are actually coming out of faith-based organizations at this time. So the Little Saints Orphanage, it's a charity organization with the sole purpose of rehabilitating, reforming, and reintegrating abandoned, abused children, physically or sexually abused children in shelters called Little Saints houses. So we bring them in from the streets, we rescue them, and we give them the best care that we can afford. And we've been doing this since 1994. So that's, we're actually just about to celebrate our 30th anniversary next year. And we've rehabilitated over 1,000 children, brought from all nook and crannies of Lagos State. Our main focus, or the children that we get, most of them are coming from Lagos State. What inspired me to start this kind of organization was simply for the love of humanity. I have empathy, serious empathy for children. In those days when I was doing my own business and preoccupied with a family, I used to see pictures of children that were abandoned in newspapers, and some of them lose their lives. And I began to feel some emotions, you know, towards these children. And I decided to act on those emotions. And thank God that God has been with me. And we were able to start the very first orphanage in Akowonjo area of Lagos State. In the first 2 years of operation, we had over 50 babies. I mean babies, beautiful babies that were abandoned in all kinds of situations. Some were found in toilets, some were found in gutters, some were found in uncompleted buildings. And these are normal babies. They had no deformity whatsoever. And it was then that I knew the seriousness of the situation in Lagos State. And the Little Saints Orphanage was actually the very first orphanage to be registered privately, a private orphanage to be registered by the Lagos State government. In those days in 1994, it was just the SOS Children's Village and the Red Cross orphanage, as well as the government motherless babies home that were in existence. So being the very first orphanage, we had a lot of work to do with vulnerable children. And they all came in. And by the time they got so many, I began to seek for other solutions because I could no longer cope with just looking after, with providing for these children. And the first solution that I was inspired with was adoption. I felt that children are not meant to be institutionalized. They are meant to be in families. And so I approached the social welfare in Lagos State, and in collaboration with the social welfare, that is the Ministry of Youth and Social Development, we started adoption. And I can say to you that those children that were brought into the orphanage at that time were eventually adopted. And to date, the orphanage alone by itself has adopted over 400 children to families in Lagos State, as well as families, you know, in other countries like the UK or in America. So Nigerians come from other countries to come and adopt babies in Lagos State. So it's been a wonderful success, adoption in Lagos State. When we first started, we were practically appealing to families to come and adopt. But I can say to you today that I have a waiting list of adopters on my table because Nigerians have imbibed adoption because they are now convinced that adoption is an enviable act of love and not lack of faith in God. And so far, the exercise has just been wonderful. It's one of the things that gives me pleasure. And right now, we have over, when the government approved Little Saints Orphanage, I think they were a bit skeptical whether we were going to do well because of the fear of baby factories and people trafficking in children. But I can say to you that Little Saints Orphanage has done very well over the years. And so because of that, Lagos State has approved over 70 orphanages so far. So we started with one in Lagos State and now we are 70. So that's good news because any child that is abandoned in Lagos State right now will find a home. Very unlike in the 90s, they will find a home because there are so many orphanages willing to give them the best care. And that's why we came together as an association to form the Association of Orphanages in Nigeria. And in Nigeria right now, we have over 3,000 orphanages. And when we started in 1994, there were very, very few. So I would say to you that the role of orphanages in the care and in the protection of vulnerable children cannot be overemphasized. Fine, they are not supposed to be institutionalized for too long, but the orphanages are doing wonderful work in caring for these children. Just yesterday, I was looking into social media and a woman had thrown her 3-month-old baby inside the river. And thank God there were good Samaritans who were around. A man jumped in and rescued that baby. And that baby has been taken to an orphanage. And that baby is alive and doing well today. That is the role of orphanages in Nigeria at the moment, in this year. So we are very, very happy about that. So our focus in orphanages are mostly on rehabilitation, making sure that the children are given good care. And the focus is on education, because these children have to be educated or else they will grow up not to be able to take care of themselves. So we are grateful for what orphanages have been able to do in Nigeria.
This is awesome. This is awesome. I must confess.
Sorry,
this is really, really awesome. Thank you for that wonderful talk. Little Saints Orphanage. Wow. I really appreciate you. I appreciate your work, your service to humanity, and pray that the orphanage will grow more.
Thank you.
Grow more. Thank you so much. Let me Olusoji Adeniyi. Olusoji Adeniyi is a social development expert, and he has over 20 years of hands-on humanitarian experience with the United Nations. He was a preparedness expert and supported the Nigeria National Platform for Disaster Risk Reduction, DRR. He is the lead facilitator and convener for the African Network for Disaster Risk Reduction and Sustainable Development. In the health sector, he supported several key initiatives of the government of Nigeria, such as the National Pandemic Preparedness and Response Plan and the National Health Emergency Management Framework. And he was a key member of the National Ebola Response Team in Nigeria. Olushola Adeniyi, I want to welcome you to the platform. We'll have just 10 minutes. Thank you. You're welcome.
Good day, everyone. I hope you can hear me.
Yes.
Can you hear me now?
Yes, yes, loud and clear.
Oh, okay, excellent. I'm excited to be here, and I want to congratulate the Nigerian Network of Nigerian Health Historian Network. I think you guys are doing a great job helping us to navigate this very, very interesting aspect of our history that we must not allow to go away. I worked with the United Nations, especially working around emergency management and humanitarian response for over a 21-year period before taking early retirement a couple of years back. And in this period, I worked around multiple environments, including working in Asia, in Africa, and finally in the headquarters in New York. But my experience at home would be the focus of this short engagement, which is to say that we came a long way ourselves. And I was so glad when Prof was analyzing the history of the Nigeria School of Hygiene and the introduction of the sanitary inspectors and how we actually passed through the various stages to become the kind of nation that we eventually became. Because if you recall very well, before COVID, the world expected that it would be a major problem in Africa. In fact, I recall that some development workers actually predicted that there would be bodies on the streets, and they were wondering how we were going to cope, because they anticipated that this is just going to expose the vulnerability of Nigerians and Africans in general. And to the glory of God and to the effort of the men and women that worked hard around getting us ready, I think we succeeded in 2020. Africa and Nigeria in particular successfully navigated the challenges of COVID. Maybe we banked more on the experience that we had with previous pandemics like Ebola that came in years before the advent of COVID-19 in 2020. Personally, I was involved in multiple humanitarian responses in Nigeria. I was part of the team that actually started the humanitarian response in the Northeast Following the Boko Haram insurgency that led to the displacement of millions of people in the northeastern part of Nigeria. Nigeria has a very large population of close to 200 million people. And so you can imagine when a region consisting of just about 3 states, having close to 10 million people were affected by the Boko Haram insurgency, which is purely, a religious insurgency, but that brings in a lot of uncertainty and insecurity, leading to multiple humanitarian crises. And of course, a lot of the people that were affected had to move out of their comfort zones because they were attacked, they were under a lot of pressure. So they moved into nearby urban cities, and then they took over almost all the space in that area. So medical systems, traditional medical practices were all overwhelmed because of the rush of the people that were running away from the insurgency. And the first challenge we had was that, in the traditional African society, everyone is your brother when they probably share the same religion with you, or they share the same ethnicity with you. Nigeria has, a very interesting cultural and ethnic diversity of over 250, tribes and groups and ethnic groups. So these people moved into those areas, those states, and they practically took over, exceeded the capacity of the water system in the states, exceeded the capacity of the medical systems. So humanitarian intervention became necessary. And just like Madam George said, a lot of religion-based organizations, a lot of civil society organizations came in to support the effort of the government. So the government was there, but the systems and the services were grossly overwhelmed. Then you talk about the ones that happened in the northwestern part of the country. Again, another very huge terrain, starting from the extreme west, northwest, where you have the Sokoto Caliphate and the rest of them, all the way to Jigawa in the closer to the north central area. And then you have several people again that were affected because of banditry and cattle rustling and all of this. So you see a lot of, events that happen, and you just have to respond as humanitarian workers. And this goes on over and over. That makes the work substantively difficult, because you as humanitarian workers, despite the fact that you bring succor to families, you are actually also at risk, because you are sworn an oath of neutrality. So even when you see people that are attacking other people and they are wounded, they are still, they still needed to be attended to. If you are distributing food items or health emergency supplies, you cannot afford not to give to them, because neutrality is something that you have to respect by international standards. But one thing that stood out for me in all of this, because it wasn't only in the north, even in the south, there were crises that were informed by, indirect causes. I mean, sometimes in health, we think that it has to be a pandemic for responses to be triggered, but sometimes flood and erosion causes a lot of damages to families and to communities. For instance, the communities down the Niger River and the Benue River, when waters are released from the Lagdo Dam in Cameroon or the Futajalon, islands in Niger and in Mali, it all comes down to, a place we call a confluence in Lokoja, and then it triggers all the way down to the Niger Delta. And you could imagine the gross effect of that. Most homes are submerged for months, and then again, government has to come in, international agencies have to come in. Agencies like UNICEF that I worked for during that period had to come in consistently, managing the large, outlay of people that are affected by those insurgencies. So you have, institutions like Medicines Without Borders, all coming in, Save the Children, all of us trying to work together as humanitarian workers, rescuing people who are running away from the flood waters. But guess what happens? Flood would mean that the water would have passed through all kinds of grounds before coming, to pass through communities. And then, of course, the water are laden by all kinds of germs and bacteria and the rest of them. And then, of course, cholera automatically follows in those situations. So you may have rescued people from the flood effects. You may have rescued them from harmed, forces and non-state actors and all of that. But you may lose them very easily to cholera. You may lose them to meningitis, because of the fact that they are going to be all packed in very non-conducive accommodation and areas where they're going to be. So these are challenges that health workers, that humanitarian workers face on a daily basis in Africa and in Nigeria in particular because of our large population. But the good thing that we see from time to time is that because all of us are now working with the sphere standards, so there are specific humanitarian response standards that have been defined for all humanitarian workers to work with. We are forced to enforce that and ensure that not only that the government is trying to monitor performance. So for quite some time, I was responsible for humanitarian performance management. And all this period, we had to make sure that each component, each area of sector that needs to deliver results, such as the Nigerian Red Cross, which is an auxiliary to the government, such as the civil society organizations that are, likely doing advocacy to make sure that the government does not leave anyone behind. And then, of course, the international organizations and the local non-governmental organizations like Mrs. George, they all have to play specific roles and responsibilities to make sure that we get to where we are today. And personally, and rounding up, I think that one of the reasons and the success factors for the success with the COVID-19 situation was because we already developed the National Pandemic Preparedness Plan during the crisis with Ebola. And thank God that Prof was in the house to explain that she was part of the setting up of the first National Reference Laboratory, for ease of identification and isolation. So we had all those groups trained in preparedness for the national pandemic. And we worked closely with the National Emergency Management Agency, closely with the Nigerian Ministry, the Federal Ministry of Health and State Ministry of Health for all vulnerable states, especially the high-risk states and communities at risk, those who are, vulnerable and have been mapped based on the National Pandemic Preparedness Plan. So all these were areas that actually showed that, Africa has come of age and has developed sufficient, capacity to manage and monitor and actually come up with successful plans that actually could be used anywhere, around the globe to show that we indeed have, come of age. So I think it's in all of this, yes, I do agree, the National Action Plan for Health brings all this together under one umbrella with the National Center for Disease Control being responsible, of course, for the pandemic and the challenges that comes from that particular space. But I want to say that it was indeed a very interesting experience for me for over 10 years in the country and, over 20 years around the globe. I was in Indonesia when they had the tsunami, and I was in Liberia and Sierra Leone when they had the civil war, and I was in the Congo when they had the Ebola crisis. So I of course in Nigeria during our own Ebola crisis as well. So these gave me a good insight into what our health professionals actually delivered during this period. Of course, we had good support from our friends across the globe, but they weren't bringing any special effect to the table. It was simply to engage with, existing professionals around what we do. And I worked with the Nigerian Institute for Medical Research in Yaba that Prof mentioned, on looking at the practicability of some of the tools that we developed for collecting sufficient on-site GPS-enabled data for rapid EMS transfer for WHO to be able to pick up data quickly enough to be able to, advise changing trends, even when isolation and has been done and, patients have been identified to have specific type of pathogens that needs to be monitored and trend, and tracked. So this was the things that happened during my years in humanitarian performance management in Africa. And I think it was a good experience. And I see that they're still, you know, following a lot of those paths. And I do not doubt that, you know, with the effort that you guys are making now, there will definitely be a lot of reason to celebrate. Thank you.
Thank you so much. Thank you for coming around, and thank you for that wonderful talk and presentation. Really appreciate your effort globally. Thank you. Really appreciate you.
My pleasure.
You continue to go higher, higher, and higher.
Thank you. Thank you very much.
Thank you. So on this note, out. So we have some questions already, which one of the network members will be reading out now. In person of Ayojo. So we'll be taking we'll be reading out some of the questions, and while we answers will be given to some of these questions. So thank you so much. So over to you, Ayo.
And thank you, Abayomi. Can everyone hear me well, please? Can everyone hear me well? Okay.
Yes, loud and clear.
Yes, we can.
Okay. So there is a question here from Efosa, and the question is, given the concept of humanitarianism, the core being humanity and humaneness, do you think humanitarian medicine is strictly NGO and private sector driven, devoid of governments directly or indirectly? Put differently, do you think private and individuals should be involved singly humanitarian medicine? So I think we should start with that one. Our speakers, Professor Taithe, Professor Bola, and then Mr. Adeniyi and Reverend George. Up to you. Okay.
Sorry, I think is it possible for us to take like 2-3 questions together in order just for us to cover some questions? Okay. You know, I'm just yeah.
Okay, for the second question is from Suto, and is it ironic that the leading imperialist questions, is it ironic that the leading imperialist countries are also leading humanitarianism? Does it speak to the limited conceptualization of humanitarianism in ways that it excludes, for instance, African support for crisis in the West? How do we overcome the coloniality of humanitarian narratives such that it does not sound like the West's benevolence to troubled Third World? And then there's another question from Mr. Taye Akinsomi. So you mentioned the Opozengo of Benjamin in correlation with DRC Congo, one of the most richest in mineral resources in Africa, yet the poorest. So what is the usefulness of humanitarian medicine, if not exploitation? Please explain.
I think that message is for Bertrand.
Okay, well, I have actually answered in the chat to some of these questions. I think the point I was trying to make is that it's difficult to define who is a humanitarian, because it's a self-definition. So a lot of actors could describe themselves as humanitarians. We've seen, for example, the military claiming to do things in the name of humanity and acting in a humanitarian fashion. I would say that since the 1990s, after the Rwanda evaluation, with the disastrous response to the mass displacement in Goma, there has been an effort to create a set of norms and standards, and if you want a quality threshold. Now, one good question is, of course, is this not possibly a trick by the largest humanitarian organizations to create a club of which they are policing the borders? And in other words, are they just rising the cost of becoming a humanitarian organization? But in reality, so many humanitarians, as we've heard today, actually come from a variety of backgrounds. There is a very easy circulation between the WHO, Ministry of Health, and humanitarian organizations. The same personnel, the same people can have have careers across these sectors. So I think it's more complicated than sociologically. It's a difficult thing to define. There is no ontological definition of what a humanitarian is. So that's one point. So the issue of is it surprising or ironic that many very large international non-governmental organizations started in the north or the west, whatever, or in the north? I don't think it is, because it's a reflection of two things. I would say humanitarianism is conditioned on two or three major technological changes in the 20th century. The ability to transfer money. That is, you can raise money in a part of the world and ship it out to the other part of the world. That happens in the 1860s. The ability to actually send medical equipment and medical resources, and the ability to report back on it through journalism. Most of these technologies were developed in northern context, and you find them in the north. So I think that's one reason it began there, but that's also a reason why it cannot remain there. It became, people in Africa can transfer money very effectively with their mobile phones. They can do it. There's a range of technologies that have been taking place. Now, the ability of shipping out a humanitarian medical team is an expensive thing. It's very expensive to send a team from one country to the next, because you need to get through a lot of regulatory frameworks and travels. But nevertheless, you find that there are some West African NGOs that were involved in Haiti in 2010. So it's not true anymore that it is a north-south relationship. And more importantly, those big NGOs like Médecins Sans Frontières now employs 26,000 people. Now, most of these people are not from the north, like 80% are not from the north. So the question then asked, and these are members of an organization. So the question is, of course, at what stage do you decide an organization is no longer of a particular nation? I think we've reached that stage about 10 years ago.
Okay, thank you, Professor Taithe. There is another question here, and could you please shed some light on the role of the WHO in humanitarian medicine? That's from Professor Noah Atta. Then there's another question from Peter Hacker. What led to the development of vaccine and drug production units in the medical compound? So I think that's to Professor Bola and Mr. Olusoji Adeniyi.
Okay, thanks, Ayo. The role of, actually I've answered this, but I'll just summarize the role of WHO. And one thing I think we all need to know is that a single organization alone cannot respond to a humanitarian crisis, because during a humanitarian crisis, there are various needs. There's the need for health, there's the need for shelter, there's the need for education, there's the need for water, and all of these needs have to be met by different organizations with different mandates. So for WHO is the lead agency for the health cluster. And the health cluster is made up of the different organizations, whether they're private, whether they're NGOs, whether they're government or international NGOs. They all come together under whatever cluster it is you are supporting. So WHO heads the health cluster, works in the coordination, works in providing the standards, working together with the other teams to identify the priorities, and also working on the plan. Then apart from that, WHO works to really ensure that in spite of the humanitarian crisis, essential health services are being provided. And what do I mean by essential health services? Pregnant women are being attended to, children are being immunized, illnesses are being taken care of. So that's part of what WHO does in the health cluster. On the second question, do I remember what the second question is now?
What led to the default of?
Now it's a very long story, but I'll just summarize it as one: a government came in for which it wasn't a priority, and I remember I mentioned the need for critical funding to ensure that these systems work and evolve. So it wasn't a priority. The funds were not available to continue the production. Another government came back and wanted to resuscitate it, but it was just done as what was a contract. So the necessary assessment, evaluations, and planning wasn't done, and it became an elephant project. And many years passed after that. So that's what happened.
Okay, thank you. Thank you very much. And there's a question for Mrs. Daly George. And there's a question here that says, I would like to know what role Little Saints play in terms of ensuring the safety of babies given out to their foster parents. Does Little Saints conduct routine visits to homes where their children had been adopted internationally? In an event where some form of unpleasant situations are found, what steps does Little Saints take in such situation? Then there's another question. I have a gender question. Growing up in Nigeria, I remember there were frequent cases of female babies abandoned or thrown away, and some orphanages were filled with more female children than male. So has this changed, or can you give a rough ratio of female/male abandoned babies and of children in your orphanage home?
The first question, actually, orphanages are not permitted by the government to do a follow-up on adopters. And I think it's because they want to protect the children. They want to protect the privacy of the families. Because as you know, in Nigeria as a whole, childlessness or not having a child in a family is still a stigma. And a lot of people are still doing adoption secretly and privately. So it's important that the children are not exposed as being adopted in many, I would say in at least 80% of the cases. Maybe just 20% are open adoptions. So in Nigeria, we're still getting used to adoption. You know, we're still trying to sensitize the public about the benefits of adoption and how important it is for children who don't have parents to be adopted. So the ministry fully are in charge of monitoring adoption in Lagos State and in Nigeria. They are in charge. And I can say to you that they are very proactive and efficient. I mean, recently we had a case of a child that was going through a lot of challenges in the home. And within 24 hours, a visit was made to that family and something was done about it. So they do the monitoring of these families. And the families are mandated by the courts because adoption is actually finalized in the courts. It's finalized in the magistrate courts. So they are mandated to report occasionally to the ministry concerning the progress of these children. And they are not allowed to take the children out of the country without the permission of the ministry. So I can say to you that the Ministry of Youth and Social Development are fully on top of this monitoring. And I think that they are doing their best so far. We've not had cases that were really, really out of hand. And then what was the other question?
The other question is, I have a gender question, growing up in Nigeria.
Okay, yes,
okay.
Yes. If I want to use Little Saints as an example, we have more female than we have boys. You know, so if that will answer your question, yes, of course, more female children are being abandoned. But on the whole, the children that are mostly abandoned are actually children that are sick, all right, children that are physically or mentally challenged. Those are the children that are mostly abandoned in Nigeria. So more girls are being abandoned than boys.
Okay, thank you very much.
All right.
And there is a question here for Mr. Olusoji Adeniyi. The Public Health Acts of Eastern and Western and Northern Nigeria of 1958 under the colonial government influences provided that each local government area had a medical officer of it to ensure as much preventative health services as possible. And where one could not be appointed, the medical officer in charge of the general hospital looking after that area must act as a medical officer of health. But we created our present states out of this regional government, but failed to provide for this humanitarian fees of the organized health systems in these states, nor even to pay, support, and retain those so appointed. So what should we do about this as a people? So
okay, I think that we should understand that we are evolving. If we move from a regional structure to a state-based structure, how many regions did we have? The northern region, the eastern region, Midwest, Southwest. That was what we had, you know, until we moved to the states, 19 states, then 27, then 36 plus 1 that we have, and people are still agitating. So no matter how we make effort, there will always be agitation, because even within a local government, because of the multi-ethnic, multi-cultural tendency that we have, because of excess, influence placed on religion, people will always want to make demands. The key thing is not whether there is a medical officer of health in charge of humanitarian action, but whether there is a system in place in the states. For instance, I was privy to the establishment of more than 21 state emergency management agencies. And each of the state emergency management agencies has a mandate to coordinate humanitarian response, irrespective of where it was happening. So I think to a large extent, that covers the need that, was the fears of the colonial masters as at that time. Those kind of needs are now subsumed under a more holistic approach in the state's emergency management agencies. What we just need to do now is to encourage the governors to see the state emergency management agencies not as a response agency, but an holistic emergency management agency, which is, the advocacy that we all need to make. Thank you.
Oh, thank you so much.
Okay.
So can Tolu give some read out some questions too? If you have some questions with you, Tolu, if you are there, please kindly read out some questions.
Okay. Thank you, Abayomi. I think on my own, I have two questions. One for Professor Olayinka. So I wanted to know about the indigenous public health practices, in particular in Yoruba land, before the onset of colonialism. What were the mode of public health practices? And to Professor Bertrand, I wanted him to share more light on the impact of humanitarianism services in maternal and infant health.
Okay, thank you. I actually answered the question in the chat, and I said, yes, there were quite a number of practices which had been indigenous in the past. Some of them are still in existence. Some of them have been useful. And I mentioned things like herbs, things like the handing down of some secrets from one generation to the other, the use of traditional birth attendants, and some of these are still in practice, like I mentioned. Some have evolved, some have been discarded, like we all know about the genital mutilation. So these things have been there. They've been in existence before colonization, but there has been a lot of involvement. There has been a lot of refining of some of them, and also some which were not helpful or could be dangerous have also been discarded. And the other question, let me just answer that, because someone particularly mentioned my name, was on whether there was a need for another agency to focus on the biology of infectious diseases and infectious agents. And I mentioned that we already have an institute which has that mandate. That's the Nigeria Medical Research Institute, the Nigeria Institute of Medical Research, NIMA, in Yaba. That is actually the mandate, and it's not, which is the scope out of NCDC. Over.
So I guess, so the point, I mean, historically, where does humanitarian medicine fit in relation to maternal health care? And I think first point I'd like to make two small points. One, the first one is that international humanitarian aid is often symbolic rather than, it's not the bulk of the delivery of aid. Most of it comes from the countries themselves. So you have to put those things in perspective. However, the emphasis on maternal health and child health is really old in humanitarian practices. It's partially linked to religious movements. So, you know, the orphanage, as we've heard, orphanages, childcare have been traditional activities of religious organizations for a very long time. So there is an inheritance from that perspective. Organizations, secular organizations like Save the Children, emerge very early on and are very powerful in conveying the nature, the brutality of a particular situation, systemic or war or what have you, and the child, in a sense, has always been the ideal humanitarian subject, because the child is by nature innocent. And I think that's a very important aspect. Now, the emphasis on maternal care, and in the 1920s and 1930s in Africa in particular, is directly linked to the fear that Africa is experiencing a catastrophic demographic crisis, a byproduct of colonialism, undoubtedly, a byproduct of globalization, of increased exposure to diseases that have spread across Africa because of colonialism to a large extent. And I think that emphasis, therefore, on maternal care and childcare becomes part of a lot of inquiries, and the Save the Children conference on 1930, which brings together all the so-called experts of the time, is really centered on this issue of maternal health care, and especially the death rate of babies and infants. And I think there's a lot of emphasis in that period, in the 1930s, on trying to improve on those particular indicators. It's interesting, of course, because survival of the child and survival of the mother are very easy health indicators. Okay, they're fairly straightforward to measure, and I think in many ways, the role of humanitarian aid went for the easy fruit, easy targets, and that's an easy health indicator to measure, not necessarily to address, but to measure.
Thank you very much for the brilliant responses. And I have two more questions here on the chat that I'd like to read out. But before then, I also have another question for Professor Bertrand. And I was thinking, if time will not permit, I'd like to have a conversation with you maybe after the seminar. So I was wondering, is it possible to situate the missionaries when we talk about humanitarian services in times of maternal and child death? First, we have colonialism, colonial masters came. Then after that, we have the medical missionaries. These two set of people were working towards engendering maternal health. Then who were the humanitarian to say? Is it possible to situate the medical missionaries in this respect? Then the other two questions that I have here is from Professor Asuzi. I hope I pronounced that correctly. First, he asked, could humanitarian medicine be better termed organized medical charity in crises and emergencies? And the other question he asked, that if the idea of humanitarian medicine is saying that there is something wrong with medicine itself, or a need to find another term for what we're talking about, is this not obvious to us all? Over to you, Professor Bertrand.
Okay, so complicated. So a small point, but I think important, that missionaries and colonialists are not the same. The missionaries and colonialists often inhabited the same space. Sometimes they followed each other. Sometimes the missionaries came first. Sometimes the military came first. But if you look at the diffusion of religious groups, they don't follow imperial boundaries. So for example, the White Fathers, who organized the Catholic missionary medicine earliest in the Catholic Church, they're not stuck to the French Empire. They actually reached out for places that later became part of the German or the British Empire. So they have an imperialism of a different kind. That's what I'm saying. They're not quite the same. The point, the second point that you raise is of course in the contemporary world. So since the 1980s onwards, humanitarian medicine has been multifarious. It's emergency medicine in a multitude of emergencies. It's often, and I think Mr. Adeniyi has shown this very well. It's a wide range of collaborative efforts between a wide range of actors, where I think humanitarians have played an important role, and against, if you want, established medical establishments, has been in the last 30, 40 years in contesting the nature of the medical market, and actually contesting the cost of drugs, the dissemination of drugs, and pleading for additional research in so-called neglected diseases, which essentially are tropical, most of them are tropical diseases that had been neglected by the big pharmaceutical industry, and contesting the cost of the compounds emerging from big pharma. Now, in my personal work, I've worked on hepatitis C, okay, which is a very small, well, it's an important disease, but it's not a very big major emergency. It kills people very slowly. But hepatitis C was the drug that cures hepatitis C was retailing at something like $120,000, okay, for 12 weeks of treatment, about 10 years ago. And now you can buy it if you're in India, you can buy it for $80 or less, $30, I believe, in some states. So I'm not saying it's only humanitarians that have achieved this. The Indian state has achieved this. The humanitarians have achieved this. There's coalitions of groups that have been contesting the economic basis on which a lot of especially drug retailing is taking place, and also trying to bring alternative technologies, because I think one of the key problems of modern medicine is the constant drift towards more expensive solutions and complex solution, and that's very visible, for example, in relation to oncology or surgery, and of course the problem is that these are not necessarily widely available. So humanitarians have often favored an ethos of looking for affordable solutions that can have similar or equal, if not superior, health outcomes. And I think it's a convoluted answer to a complex question, but thank you very much for your question.
Yes, thank you. We have a few minutes left, but before we actually close for the day, we have some questions here. And before Oluwaseola Daniel will be asking some questions, there is a question from Professor Kenneth here. Says that, may I find out if there are efforts to mainstream aspect of humanitarian and emergency medicine in history curriculum at the university in Nigeria? And is it already in the curriculum? Do I actually say that we allow a prof to ask his question, because I can see his hand up. So can Daniel read out his questions to maybe if Professor Kenneth can still ask some questions, or maybe any contribution, I don't know. So please, Daniel, quickly, can you just read out some questions before we call it a day? Thank you.
Okay. Thank you for letting me do that. The question I have here, the first one from my side has not been answered. How can we describe the existing human resource in public health response in Africa and Nigeria in particular? And I think the last one will be directed at the organizers. Please, could you share the recording of this seminar? Yeah, I think that one should be on YouTube, I think. Yeah, I think that's
okay. Let me take the human resources, the health, human resources. I think that we have a wonderful opportunity. I mean, there's a lot of attrition as we speak. A lot of medical health professionals are attracted to the developed countries to practice based on several factors. One of it, which is the quality of pay, the environment of practice, the availability of appropriate technology and equipment to support their work. Everyone wants to work in an environment that is conducive for efficiency and effectiveness in their professional life. But I see it positively in my own personal space, because I believe that whether you are talking about experienced consultants or medical assistants or nursing officers, all these can actually be turned on its head, and we can become a mass production centers for all these technology-based skills, whether they're in the medical field or in the engineering field or any kind of fields at all, that can produce the number of required professionals that the world needs. Because eventually these people will give back to their country at some point or the other, either when they're tired of being abroad, or I was abroad for several years, but at some point I decided to return home to support the country. While I was abroad, I was still remitting home some substantive amount of my income. So I do not see it negatively the way people see it. They call it the Jackpot syndrome, and every young one just sees it as the next big thing to happen. And so the people in the industry are also seeing it as depletion of the workforce. And then, of course, there are lots of gaps in the industry. But we have also placed certain restrictions on our faculties of medicine, on our medical colleges, on our research institutes, that prevents the number of people that we need to produce, to actually be produced on an annual basis. We have strikes, we have all kinds of things that restrict it. We have our laboratories that need to be upgraded. So if the country would turn its eyes on those facilities, those institutions, those universities, and set up chairs and faculties and systems that will produce what the world needs, they will have sufficient for the country. We have 200 million people that would need to be attended to. So there will always be, those who would stay, and those who would want to go can also go on even an arrangement that is sponsored by the government, that you would go, you would, be able to pay for your residency and whatever it is that you want to do there using a loan facility from the government, and then you will pay back. And then, of course, government can also make incomes and revenue from such export of intellectual capacities. Thank you.
I think you're right. So straightforward. And I think one of the interesting points about humanitarian medicine in the last 30, 40 years, if you want, is that we moved away from just disaster response or the most acute form of response. And now humanitarian medical practitioners are involved in things like how do you deal with diabetes, with heart disease, with cancer? Things that are becoming more and more common as basically Africans start eating not so well anymore, and the result is so diet issues, lifestyle issues are becoming more central to the concerns, and that means the boundaries between this emergency medical world of humanitarianism of the past and what we just call public health is really, really thin now. And I'm seeing it in many places. Humanitarians are asking themselves, well, we really need to engage with those issues that are much broader, much more social issues than just responding to a flood or a famine or an earthquake or a war.
All right. Thank you so much. We appreciate you. I think we are like 6 minutes behind the schedule time. So we want to say apology for for using that 6 minutes. So we appreciate you for coming. It's been a wonderful session, and we really appreciate you on the seminar on the value of history of humanitarian medicine and public health emergency response in Africa. Want to appreciate our speakers, the Taithe, Olayinka, Daily George, and Soji Adeniyi for coming to enlighten us and open our heart and our mind to things we've not even take cognizance of before. So we really appreciate you, and thank you for everyone on the meeting tonight. We also appreciate you. Out of your tight schedules, you still find time to attend. So we really appreciate you. So we'll be having this seminar time to time, and we really love you join and partake. We want to learn more from you. We want to learn more from you. So to develop Africa. So, and I really want you here. So on behalf of Nigerian Health Historians Network, we are saying a very big thank you to you. Zoom is still open for networking. If you want to network, want to meet people, so kindly do that. Please, you still have some minutes to do that, but the meeting is over. But if you still want to be on the Zoom to meet your friends or to network with people, so kindly go ahead and do so. So what we say a very big thank you to everyone for coming. Thank you so much.
Thank you very much. Goodbye.
Thank you. Enjoy the rest of your evening.
Thank you.
Thank you. Thank you.
Thank you to the speakers. Thank you for everyone. Thank you.
Thank you.